My name is Fay Lang. I'm a radiologist at Georgetown University Medical Center in Washington, D.C. And today I'm going to be discussing the use of ultrasound of the gravid cervix. So today we're going to discuss imaging the cervix in pregnancy using ultrasound and hopefully address some issues that we can call some helpful hints. When we think about measuring the cervix, we typically begin at about 24 weeks, and we can see there's a range here from the 10th to the 75th percentile, and the normal range is somewhere between 26 and 50 millimeters. The reason we choose 24 weeks is because that is more or less the cutoff at which a baby can be born after 24 weeks and survive, whereas before that time, most of these babies will not be viable outside the uterus. When we look at the cervix, as we can see here diagrammatically from Dr. Netter's diagram, the length of the cervix seen between this line and this line, measured that way. There are several ways to measure the length of the cervix. Certainly, the most common is the digital pelvic exam, but there are problems with using this. It's the most common, but it has anatomic problems. One is, as we can see here, the upper border of the vagina ends at this point here where the fornices are. So if you're doing a digital exam, you certainly can't palpate the proximal half of the cervix. It's a subjective evaluation. If you do a digital exam, you say, I think it measures so many centimeters long, but you can't take a picture of that. There certainly could be a risk of infection, especially if the membranes are ruptured. And even if they're not, if the membranes are coming down through the cervix, you could potentially rupture membranes. So it has a problem. If you compare the digital measurement of the cervix compared to ultrasound using a vaginal measurement, using vaginal ultrasound, we can see that on ultrasound, the length of the cervix is considerably longer than the digital exam. But that should not surprise you because, again, when you measure the cervix digitally, you're missing the whole proximal half of the cervix. So ultrasound is really the gold standard for evaluating the gravid cervix. There are several ways this can be done: transabdominally, translabially, and transvaginally, and we'll talk about each of these, starting with the transabdominal examination to measure the cervix, the most common way to do it, but the least accurate. Well, what are the problems with using a transabdominal approach? Some of it is a problem with the bladder. It could be too full, it could be too empty, and sometimes either due to an empty bladder or overlying fetal parts, the cervix may be obscured. So here's an example where the bladder is too full. It compresses not just the cervix together, but it drags the lower uterine segment, the anterior wall of it, against the posterior wall, causing it to look too long. It increases the measured length of the cervix, and actually the cervix is not that long. It's just compressing the lower uterine segment together. If it does so, as in this case, in the placenta, as we can see here, gets dragged along with the lower uterine segment, you could think there might be a placenta previa. So that would increase the false positive diagnosis of placenta previa. Well, how do you address this really from a practical point of view? Here's a lady who gets an A+ for filling her bladder. It's very distended, and it doesn't really look like there's any problem. Well, I would very much urge you to realize that ultrasound is not done in a vacuum. You need to have a clinical history. And in this woman, actually, she had recurrent miscarriages in the mid-trimester of her pregnancy. So this is not an acceptable view because we already said her bladder might be compressing the cervix. So in this woman, when we emptied her bladder and went on to the next way of looking at her, in this case a translabial scan, we can see that her cervix is entirely dilated. It was just being compressed by this full bladder, and between the calipers here is the endocervical canal. So she's completely dilated, and that was completely missed due to the fact that her bladder was so distended and compressed the walls of her cervix. But it was her history that was the clue not to allow us to stop the scan at this point when her bladder was so full. Having an empty bladder can also be a problem if it's too empty. There can be acoustic shadowing, as we see here, denoted by the asterisks, and there is loss of the acoustic window, as we can see. We just don't have a good window to work through. Now, why are you seeing the shadow here? Well, one thing is you may be scanning over the pubic bone, and you may be seeing shadowing from the bone. Another is with the empty bladder, there's an angulation problem here between the bladder and the fluid in the uterus, causing some of the sound to be reflected away from the transducer, and hence the acoustic shadow. So these are technical problems that can lead to problems. A completely empty bladder, as in this case, may be confusing. Somebody who doesn't have a lot of experience may look at this case and think, wow, that cervix looks entirely dilated, with this being the internal and that the external cervical os. And in point of fact, whenever there's a problem or you're questioning something like this, I think it's a good idea to scan the patient in a different manner. In this case, we went on to a translabial scan. We can see her her cervix is completely closed. The anterior versus the posterior wall, the endocervical canal here, completely closed. What happened here was when her bladder was totally empty, as we can see here, something has to occupy the space where the bladder was. And so what happens is her uterus actually becomes more vertical, and so does the cervix. So here would be the internal os, the external os. The endocervical canal is seen, it's a line in this position, and you really can't resolve it because you're looking straight down along its course. Coming in by a translabial, or if you wanted a transvaginal route this way, we're 90 degrees to the position of the cervix, and therefore now, here's the coming down with the translabial scan, we're pointing directly looking at the endocervical canal, and hence we can resolve this issue. Sometimes, again, acoustic shadowing is seen here, limiting our ability to look at the cervix. And again, the bladder's quite empty. Is there a better way we can approach this cervix? And the answer here is yes. And we see, not an ideal picture perhaps, but certainly I can measure the length of the cervix here, internal, external os. What is the difference between these two scans? The difference is the transducer that I chose. On the first image, I'm using a large-faced curved array transducer, and here I am using a sector scan. A sector probe I can position better in areas of limited view. I can push against the baby's head, which we did here. Notice here the head is lower. By taking that probe and coming just over the pubic bone, pushing a little bit with it, getting the presenting cranium out of the way, I now have a better ability to look at the cervix. So I would like to make a pitch, if you can, if you have this transducer available, a sector, in cases where you can't see the cervix well and you're scanning transabdominally, change to a smaller face transducer such as the sector probe. See if you can manipulate things and get a better look at the cervix. What about this case? Again, using a sector scanner abdominally, it looks like the internal os is open, and people might say there's a dilated cervix at that point. But again, if there's a question and you're unclear, look at it from a different approach. Here again, we went to a translabial scan, and we can see that the cervix from here to here is measuring 34 millimeters, and it's normal. So what is going on in this case? Why is the cervix normal here, but what is the problem here? Well, people who have had experience quickly recognize that what we're dealing with here is a lower uterine segment contraction, either a contraction that may be resolving or one that's actually forming. And it has this typical keyhole appearance. If you could force yourself to look beyond that keyhole, here is the normal cervix. But I urge you, if you have a question, go ahead and look at the patient using an alternate approach. And by that I mean either a translabial or a transvaginal approach. So we've already mentioned that there are problems with transabdominal scans, but we usually get away with it. It's the most common way we look, but we've discussed some of the problems. As you're looking at the cervix transabdominally, I also would suggest you take dedicated images of it. Do some cone-down views of the cervix, look more than once, particularly if a woman is having contractions, because when a woman has a contraction, the cervix tends to shorten and dilate, and that would be a time when you might see that it's not looking quite as normal as it did when she was not having a contraction. Have the bladder relatively empty, not too full, where you can compress the cervical walls together, and not too empty, sort of moderate. And very important in yellow italics, patient's history is critically important as to when you might want to go and do either a translabial or a transvaginal scan. So let's next address translabial scans, and what we're doing here schematically, you can see the transducer, you can see it has, in this case we're using a sector, and you can see the orientation of the cervix. Notice the patient's bladder would be empty when we do this. And what's really important for those of you who have not done translabial scans, and the same is addressed with transvaginal scans, is to get used to how you look at the monitor, which is 90 degrees counterclockwise. You always put the top of the probe at the top of the image on the monitor, even though you can see here we're coming in from the patient's feet toward her head. What we do is we take the transducer, and then it depends on, you can cover it with some kind of protective device, and one of the things we use is just a plastic sandwich baggie. You put a little transducer gel over the probe, then you cover it with a baggie, a sandwich baggie, and then you put a little more transducer gel and you're ready to go. And hopefully you can image and see what looks like the cervix. Just the landmarks that we're looking at now, we said the transducer probe is here, so it looks like the patient's feet are pointing to the ceiling. That's obviously not the case, but the image on the monitor is rotated 90 degrees counterclockwise. So that's where the vagina is. This is the anterior and the posterior cervix that we're looking at, and we can see the endocervical canal right there. And the problem with this approach, you can see here, is acoustic shadowing due to overlying bowel loops, the rectosigmoid, typically in this area, making it very difficult, if not impossible, in a fair number of cases, to see the external cervical os due to that shadowing. In which case, if you're being asked to measure the length of the cervix and there's bowel in the way, you won't be able to get an effective measurement. If you're new at this and you're having trouble lining up the anatomy as I just showed you, I suggest you start with a coronal scan, which is basically holding the probe horizontally or transversely as you place the probe at the level of the introitus. And start with the coronal scan. And what it looks like is similar to what you might see if you were placing a speculum in and looking for the cervix. You can see the rounded cervix. This is the endocervical mucosa. The little horizontal line there is where the walls of the cervical walls come together, and that is the endocervical canal itself. And take that line and then pivot on it. And when you pivot on it, hopefully you will see that endocervical line, as we're seeing here, endocervical mucosa, and the anterior and posterior walls of the cervix. So hopefully that little tip will help you in your orientation. Now, when do you do these translabial, transvaginal scans? Well, we've already said when the transabdominal scan, if you're having a question. And why do you usually have a question? Well, you're often worried, is there a problem with the cervix? May it be dilated or effaced? If there's a question of placenta previa and you're not seeing the relationship of the placenta to the internal os, well, on a transabdominal approach, you go to the next level. So when might the cervix be effaced or dilated? Any woman who has a history in the past of preterm labor is at risk for having it again. And I did show you one example where it looked okay with a very distended bladder and it was totally dilated when we went to the translabial scan. So if there's a question of cervical incompetence, is her cervix not holding up well? If she has preterm rupture of her membranes. Any patient where there's a question of ruptured membranes, you do not want to do a vaginal scan because the potential is you could introduce infection if the membranes are ruptured. So again, a translabial scan would be a good way to look at that woman. Following placement of a cerclage is another situation where you might see it better using a translabial scan or a transvaginal scan. So let's look at this diagram. What happens to the cervix when it dilates? And these diagrams tell you what happens to the cervix whether you're dilating at term or preterm. The non-dilated cervix, we're seeing the anterior and the posterior walls of the cervix here schematically, the endocervical canal here, and its relationship to the internal os forms the letter T. Now, as the cervix begins to dilate either at term or at preterm, it then dilates from the internal os toward the external os. So here diagrammatically it assumes the letter Y, V, and then ultimately as it's entirely dilated, the letter U. And Dr. Zilianti in this article a number of years ago, this was from his work, and he says, trust your vaginal ultrasound, TYVU. And I just thought that was kind of cute. You don't really have to remember it, but just remember that the internal os dilates first, and then the dilatation progresses from the internal down toward the external os. So here we have a nice example of the letter T. The cervix is completely flattened at the internal os level here, and that's what we'd expect. And I'm going to draw your attention to the fact that if you really want to see that internal os, it's important to get a little bit of fluid, if you can, to be just in front of the internal os so you have the conspicuity to see it. You've got to try, therefore, to pull the presenting part up away from that internal os. One of the things I do, and remember these women have empty bladders, so the baby wants to come down low, is ask the mother, if she could, to place her hands low in her lower pelvis, see if she can actually pull the baby up. It only takes a couple of millimeters to give you fluid and get a scan that is technically optimal. And I'm going to come back to this point of why it's so important to have a little bit of fluid in front of the os. One is so you can see the internal os, and I'll get back to this point later as to another reason why it's important. So here's a normal cervix, the letter T. Here's one that's starting to dilate again from the internal os, the letter Y, more dilated, the letter V, and this one is completely dilated, the letter U. Now notice that this scan, this is actually done transabdominally. We start all of our scans initially transabdominally. If I saw what looked like a completely dilated cervix, as in this case, I don't really think there's any indication to do a transvaginal scan. You might want to do a translabial scan, but not a transvaginal scan. Again, you could have the membranes starting to herniate through. You do not want to possibly rupture the membrane, and your probe itself might cause the already dilated cervix to become even more irritable. So if you see a completely dilated cervix like this, it's time to get the clinician involved quickly. Don't stand the patient up, just get her upstairs on a flat gurney. You don't even want the pressure when she stands of that fluid to push down against her cervix, because in that process, perhaps the baby may start coming out as well. So that's, once you see a dilating cervix, get the patient to have some, see the obstetrician, and don't have her stand up. Now, when we're measuring the cervix, the most important measurement is to measure the residual length of closed cervix. As the cervix dilates, as we can see here from the internal os, the lower aspect of the lower uterine segment and the upper cervix sort of become one unit, and it's really impossible to measure, I think, where the cervix actually started. At what point is this the internal os? So we want to concentrate on the area of the cervix that is not dilated. So you've got to see this point, and then it's incumbent upon us to also see the external os, as you can see here. So that's what you want to measure. And what measurement do we start getting worried about? Well, the magic number is 30 millimeters. Remember I said the normal cervix has a range. And I said it starts at 26 millimeters. But from a practical point of view, 30 millimeters is considered a good cutoff. We will have some false positives. There will be some women whose cervix is less than 30 millimeters, but she's not abnormally dilated. But the reason this is an important number, you can see Dr. Imes does considerable work in publications on the cervix, and in this particular very good article with a discussion about the probability of preterm delivery. If you take 30 millimeters, now this is 20, 0, so we're shortening our cervix, and the probability of delivery, you can see, starts to rise very dramatically as the cervix progresses to become shorter and shorter. So it's our philosophy that once the cervix measures 30 or less, we get on the phone and we call the clinician. And you can see a comparison here between ultrasound and the clinical evaluation vis-a-vis predicting preterm preterm birth before 36 weeks in terms of these important statistics. Ultrasound does better than the clinical exam with respect to evaluating that cervix. So it's really quite critical to be able to measure that cervix, and again, 30 millimeters or less is concerning. Now, sometimes the cervix has an unusual shape known as an hourglass cervix. What happens here is that the cervix is completely distended, but it's not all that dilated because fluid herniates out where the membranes herniate through the external os into the vagina. So now the vagina contains membranes herniating through with fluid, and it has a greater ability to distend than does the cervix. So the cervix may be rather non-dilated compared to the fluid in the vagina. Hence, you get this more or less hourglass configuration. And to those of you who have not seen it before, it might be confusing because you may fail to understand the anatomy. So let's look at this hourglass here, hourglass seen on this little diagram here or picture. What are we looking at? That is the cervix. And you can see it is not as distended as the fluid that's in the vagina. And when you see this, notice again, we're starting transabdominally. This is a patient in whom you do not want to put anything into her vagina because you might rupture those membranes or you may give her an infection, and that is a disaster. You get on the phone, you call the clinician, you don't let the patient stand up, you send her upstairs on a gurney to be evaluated by the obstetricians at this point. Here's another example. And again, notice how this endocervical canal, which is completely dilated, is not that distended. The diameter is not that great because so much fluid is present in the vagina, which can accommodate this large amount of fluid. Notice also in this case, what's coming into the endocervical canal is the umbilical cord. So that's a really bad situation when you have a cord presentation. And here's another one. Not that dilated, but accommodating a lower extremity and the foot, which is sitting in the vagina. And here are the membranes, again, that you can see herniating into the vagina, containing echogenic fluid. That's not uncommon late in pregnancy. So several examples now to recognize of hourglass cervix, and all done and appreciated with a transabdominal scan, and you do not want to do a transvaginal scan in these patients. So now that we've discussed varying approaches to look at the cervix, some of the problems, we've mentioned the hourglass cervix, let's talk about some of the problems you may encounter. Here's a patient measured on a transvaginal scan, EV, transvaginal, and the cervical length looks fine. It's about 4 centimeters in length. But now it's 2.5 centimeters. Well, what's going on here? That's too short, but that's normal. What is the difference between these two scans? The difference is that this woman, by history, it sounded like she had an irritable cervix. So what we actually did here was we put pressure with our hands on the upper aspect of her uterus toward the fundus, and with our hands we pushed from the fundus in a direction down toward the cervix. We were putting pressure against her internal os, and because it was irritable, her cervix started to dilate, again by the internal os first. So it decreased by 15 millimeters with that fundic pressure. That's analogous to if a woman, again, if she's having a contraction, then physiologically she's putting pressure against that internal os, which is why, as I've already said, at the time of a contraction, go and look at the cervix because it might be getting shorter. If she's not actively having contractions but you're concerned, see if you can put pressure against it by putting pressure on the fundus and pushing down in the direction of the internal cervical os. So here's an example where the cervix looks relatively okay. Now I'm going to show you a clip as we're applying fundal pressure in this woman. As we do so, you can see how her internal os is starting to dilate and her cervix is getting shorter. What about this patient? This cervix looks fine. It's more than 4 centimeters long. Looks great. But now, within a period of just a couple of minutes or so, her cervix has shortened greatly. And what's going on here? In 2 minutes, it spontaneously decreased. She was having a contraction. She had an irritable cervix. So be aware of this. One other point I'd like to make. When you put the vaginal probe in to do this, don't just put it in and then just pull it out 10 seconds later, because it's just my general feeling that when you first put that probe in, the cervix, if it was dilated, may decide it doesn't like the probe in there and it starts to go back to a more normal appearance. So when you put the probe in, I would suggest you keep it in for at least 1 or 2 minutes, talk to the patient, try to get her to relax, and see if you have a more physiologic appearance to that cervix. Because when you first put the probe in, I think the doors slam shut, and that is something you don't want to have a normal looking cervix if it's really dilated. So you want to pick up all the cases you can. Here's another example where you might think that cervix looks, it's a little bit of, maybe the letter Y might come to your thought here because of that V-like appearance at the internal os. But look at this cervix. Oh, wow, look at it. It's totally dilated. Well, why is it here it looks okay and here it's so totally dilated? It doesn't look absolutely okay, but certainly a lot worse here. Well, what's happened here is that when that vaginal probe was put in, it was compressing the walls of the cervix. In other words, we were pushing with the probe, compressing the anterior against the posterior wall of the cervix. I'm going to show you a clip in just a second. Here we go. As I push with the vaginal probe, I can push the anterior wall of the cervix against the posterior wall. And I would suggest you not do this because I think if the cervix is already this irritable, it's not going to be happy when you push the probe like this. I also want to mention I am not pushing the probe over and over and over here. This is just one push, but the clip goes around and around and around. Once I see that the cervix is dilated, do not push that probe in so hard that you're compressing its walls. You don't want to have a normal-looking scan when it's not normal. Here's another example. That cervix looks perfectly fine. And if you measured it, it's a normal measurement. Notice also where we put our calipers because it's a slightly curved cervix. So this is a sum of these different measurements. This one plus this one is a normal length cervix. But now you measure the same patient, it's only 2 centimeters. And this is again an effect of pushing too hard against the cervix with the vaginal probe. And I'm going to show you a clip in this case to show you what's going on. Cervix is too short here, and the clip now, as I'm releasing pressure against the cervix with the probe, I think you can appreciate it was longer and now it's shorter. It's longer and now it's shorter as I'm pulling back with the transducer. So don't push that cervix, don't make it look closed or longer than it really is by having transducer pressure against the cervix. What about this case? This is done transabdominally. Now, if you're busy and somebody just shows you this, it might be very easy to say, that looks like a normal cervix. Oh, but now it doesn't. Now it looks like there's fluid in the endocervical canal. So what's going on here? Actually, that's not the cervical wall. That is a foot in the endocervical canal. Here it is. You see it sort of moving just a little bit. And then this baby cooperated, pulled the foot right out of the endocervical canal, and you can see it's a totally dilated cervix. So there are some situations which I'll call a false negative because the cervix looks normal, but it's really not. And you want to avoid these situations. The things, again, to review that could get you in trouble is that overly distended urinary bladder, if the cervix is irritable, but the patient's not actively contracting and you fail to do fundic pressure maneuver, that is pushing your hands, taking them on the top of the fundus and pushing them down in the direction of the internal os. Intermittent dilatation, pushing too hard with the probe, compressing the walls of the cervix, and an unusual situation where there may be fetal parts in the endocervical canal. Now, let's flip the page and see if the opposite might occur, where you might think the cervix is abnormal in terms of fluid in it or distension, and it's really not, okay? A false positive diagnosis. Let's look at some examples. This cervix looks like it might be dilated because it looks like there could be fluid in the endocervical canal. But in point of fact, if you look at the clip carefully, that's a little white line here that you're seeing, which is actually the opposing walls of the cervix. That's actually the endocervical canal. And so therefore there's not fluid, but most people have more echogenic mucosa of their cervix. So in this case, for whatever reason, I don't know, that the echogenic endocervical mucosa is lacking. It's unusually lucent. But if you look at this case, sagittally and coronally, there's no line here. There's no dot here. That is actually fluid in the endocervical canal. Lack of seeing that endocervical stripe, and I'd suggest you do this in two directions and look completely from side to side. Make sure there's no endocervical dot or stripe here to suggest that it's lucent mucosa. So that's truly dilated, and this is pseudo-dilated because you're seeing that endocervical line here. So that's very, very important. You don't want to miss a case, and you don't want to overcall a case. What about this case? Well, the cervix, this is translabial, measures 27 millimeters. That's shorter than the 30 millimeters. So we shouldn't be happy with this measurement. But is this really a good scan? Again, it's translabial. Could there be a technical problem? Well, look at the big time shadowing here, obscuring the external os. That's due to the rectosigmoid bowel gas. When you have that, you can't have it's a technically suboptimal scan. And, you know, we're always wanting to put calipers on and do measurements. Well, be careful before you do that. Make sure your scan is technically appropriate because that bowel gas is causing a problem here. Her cervix is not short. When we did a transvaginal scan in this case, you work around that bowel gas, and now we have a normal length cervix. Okay, so that's an important false positive. That's a major problem with a translabial scan, the inability to see the external os because of acoustic shadowing from adjacent rectosigmoid bowel. What about this case? Again, we always want to do our measurements. So here you put a little caliper here, and then that's the other end. You put a caliper here, and how do you measure it? Well, some people might just draw a line because that's easy. But is it good? Absolutely not. That line measures 28 millimeters, and I'm sure you realize that is not the course that her cervix is taking. That's a linear measurement, and her cervix is curved. So you've got to take the time to trace out the way that cervix really, the endocervical canal, the course of it, and in this case it's 42 millimeters. That's appropriate. The linear measurement of 18 millimeters, that is inappropriate. They don't equate. Take the time, look at the course of the endocervical canal and measure it. I think that this configuration of the curved cervix is not that much of a problem in the third trimester when the cervix is actually, I think, more linear in most cases, but sometimes in the second trimester. And after all, women who have incompetent cervix, that's the time you might want to be following these women. And just don't be sloppy. Put your calipers on appropriately. Get a good measurement. So some of the pitfalls that would be false positives, meaning that you think it's abnormal, but it's really not, it's normal, would be times when you could have what looks like endocervical fluid. The bladder can cause that. You can have fluid from Nabothian cyst or vaginal fluid. We talked about lack of cervical mucus. And the big one is shadowing from adjacent rectosigmoid bowel, causing you not to be able to see the external os when you're doing a translabial scan. The curved cervix is one other pitfall from a technical measuring point, okay? So when we're talking about evaluating the gravid cervix, we've already said transabdominal scan, done most common, but not as good as the other two ways of looking. Translabial scan is good, but it has the problem, particularly with the external os, giving us some limitations when we have to measure its length. Transvaginal is the best. Now, I'm not going to spend too much time about diagnosing placenta previa, but I want to make some important points. One is we're good for making the diagnosis. Two is that we overcall it. We have false positive diagnoses, so our specificity is clearly under 100%. And what are the problems that we have relate to technical factors? Okay, we already addressed how full the bladder is. That's a technical problem. The degree of previa and the gestational age. I'm sure most of you realize that we particularly overcall earlier on in the second trimester, and then the cervix seems to, or the placenta seems to move away later in pregnancy. So if you're going to be diagnosing previa in the second trimester, make sure you get a follow-up, because there are many cases later on when the cervix is no longer a previa. Also, from a technical point of view, we talked about the bladder distension. Realize that the cervix itself is almost like, let's say a roll of paper towels, okay? It has an anterior component, posterior, and two lateral components. That's all the towels against the cylinder of the paper towels, whereas the endocervical canal. And if you were just to do a sagittal scan and you were insisted on looking at the midline, you could miss a placenta that's coming in from the side. This is a transabdominal approach, and we're looking at a transverse view of the cervix. So in this case, the placenta is on the left side of the uterus, and it's clearly coming upon the ipsilateral cervical wall, not crossing over the internal os, but on the cervix per se. And if all you did was a sagittal midline scan, you would miss that. So make sure you scan from multiple planes and go through the entire cervix. So this would be a placenta that we would call a marginal placenta previa. I'm sure many of you have noted, and we've already mentioned, that the placenta moves with time. Here's an example where there's a posterior placenta there, and it ends here. This is a translabial scan, and this is the endocervical canal. So this placenta is completely crossing over the cervix. It's a placenta previa. But now, 6 weeks later, the same case, again, a translabial scan. Now the placenta is ending here, and the internal os is here. Anterior posterior wall of the cervix here. So now this placenta is just coming to the edge of the posterior wall of the cervix. Some people might call that low-lying if this measurement is less than 2 centimeters. That is the term that we use today for a low-lying placenta. So we've gone from a complete previa here to a low-lying placenta in 6 weeks. Well, what is going on here? What is causing this? A wonderful concept was termed by a Dr. Bernershka, and he is a placental pathologist, believe it or not, at the University of California, San Diego. And he coined this process of the moving placenta due to a concept, he called it trophotropism, responsible for migration. Well, what exactly is this concept? The concept is that the placenta likes a good blood flow. And it actually has been shown to proliferate where there is a good blood flow and atrophy where there is a poor blood flow. and the lower portion of the uterus does not have as good a blood supply as the upper portion of the uterus. So with time, if you have a placenta that was in the lower uterine segment or even over the cervix, with time, because there's poor blood supply there, it tends to atrophy and it tends to proliferate on the opposite side, growing up toward the upper body and fundic portion of the uterus. So let's look at this process schematically. A normal placenta is a discoid structure. The cord in most people starts centrally, as we see here. Now let's say that this portion of the placenta was in an area of poor blood supply. Let's say it was over the cervix. With time, that portion of the placenta might atrophy, as we're seeing here in white, and going up toward the upper uterus, it would proliferate here. The cord does not change its location. It stays here. And what I really like about this concept, not only does it explain the, quote, migrating placenta, but it also explains some placental anomalies, such as when the cord inserts now at the margin of the placenta, that is called a marginal cord insertion. Some people have called that a so-called battledore placental appearance. So if this continues, this process, let's say now we're still over the cervix here, and we continue to have atrophy and concomitant growth of the placenta up high, now you might have a situation where the cord is not even on the placenta any longer. It is on the fetal membranes that are here, but it is not on the placenta. Well, what do you call this? We call that marginal. What do you call it when the cord inserts on the fetal membranes, but not on the placenta? You call that a velamentous cord insertion. And this is a very important concept, because if this situation occurs and you have a velamentous cord insertion and these membranes now are overlying the cervix, you call that a vasa previa. We're going to talk a bit more about vasa previa, but it is a very, very important situation, because if a woman attempts to deliver a baby in this situation through a vasa previa, that baby has about a 50% chance of exsanguinating. And that is something that is exceedingly dangerous, therefore. So this is what a velamentous cord looks like. The cord itself is not attaching directly onto the placenta. It attaches onto the fetal membranes, and as you can see here, it breaks up, as we see here, into various vessels to a variable degree. So this is velamentous, and if this is over the cervix, it's a vasa previa. Every vasa previa is velamentous, but not every velamentous situation is over the cervix. So therefore, not every velamentous situation is a vasa previa. There are even websites that address this, and you can see here that this placenta has a velamentous cord coming over the cervix, i.e. a vasa previa. So what is the take-home message here? If you think about it, this woman earlier in pregnancy might have had a placenta previa. The good news is, if you want to think about this, the good news is the placenta migrated. She no longer has a placenta previa. But the very, very, very bad news is that she may be left with a vasa previa, a bad, bad situation. So a migrating placenta is not always a good thing. So how do we make this diagnosis? Well, you have to be wary of a migrating placenta previa. You have to be very in tune to where does the cord insert on those placentas that appear to migrate. You really need to use, I think, color Doppler to look for the placental cord insertion site. And I'll show you this in just a minute. If you see cord vessels in front of the cervix, it's diagnostic for vasa previa. What do I mean by cord vessels? It's not hard to determine. You put your Doppler on, you determine what is the heart rate, or you put your M mode on, determine what is the heart rate in those vessels, and you compare it to the fetal heart rate. And if they're one and the same, those are cord vessels, okay? So here we have an example. You can see the placenta here. You see what looks like cord here, and you determine that's the cord, and you determine the heart rate there. It's the same as the fetal heart rate. That is a vasa previa, and here is the cervix down here at this level. So that is right over the cervix. Here's a different patient. There is a breakup of the cord into its various membrane components, but it is not over the cervix. So this is a velamentous cord that's breaking up, and it attaches somewhere else to the placenta. These vessels do, but it's not over the cervix. So this is velamentous, and this is velamentous, but over the cervix, hence we used the word vasa previa. So let's look at a few examples. Here's a patient who has a placenta. Here's the cervix. There's a little vessel there. Well, what is that vessel? You have to determine if that is going at a fetal heart rate. You put your Doppler on in this case. It's going at a fetal heart rate. That is a vasa previa. So even though it looks pretty innocuous here on the color image, it's not at all innocuous. This is a vasa previa. This lady needs to be delivered by cesarean section, even if the placenta disappears and is no longer on the cervix. The fact the cord vessels are on the cervix makes her non-deliverable from a vaginal point of view. So she needs to be sectioned. Now, remember a while ago I said when you're going to measure the cervix, I said you want to pull the presenting part up so it's not overlying the internal os. You'll get a better measurement, you'll see the internal os better, and there's another reason why. This lady actually had a placenta previa, and then she was told her placenta migrated. Good news, no longer has a placenta previa. Then she came back in with a little bit of bleeding, and when we looked more carefully, that is, by pulling the presenting part off, away from the internal os area, which would be here, we noted a little vessel here that you could never see when the presenting part was up against the internal aspect of the internal os of the cervix and plastered against the cervix itself. So we started getting concerned. We looked harder, and we were concerned about this, and I'll show you a clip in a minute. There you go. There's a vessel that's coming completely over, you can see over the internal os, over the entire cervix. And then what you want to do is to determine what is the heart rate in that vessel, how many beats per minute. This is at the fetal heart rate. This is a vasa previa. Here's an example where that patient had been told everything was fine, her placenta had migrated, and nobody made the effort to see what was going on over her cervix. And that is so critical. I know I'm emphasizing this point over and over, but it's critical because if that baby had, an attempt to deliver her from below, she would have about a 50% chance of exsanguinating because as these vessels tear, this is fetal blood. That is, she's bleeding out fetal blood and the baby has a high rate of exsanguination. Can you ever have an error and think it looks like a vasa previa, but it's not? Well, here's an example. This is the cervix, here's the fetal head, and these are cord vessels. You can see the heart rate here is going fast. It's the same as the fetus cord vessels, but this is a sneaky case because this is not the cord fixed over the cervix. As a matter of fact, in this woman, when you looked, where's the cord inserting? Her cord is inserting normally on the posterior aspect of the placenta. And she had a cord that was just sort of wandering and was in front of the head of the baby. The cord can move around, the floating cord. And in this case, it was just in front of her cervix. This lady was not in labor. A few minutes later, that cord moved out of the way. Now, if she was in labor and the cord is the presenting part, that lady also needs to be delivered by a C-section because you don't want the cord to come down before the head and get compressed and the baby become anoxic on that point. I think an important take-home message is if you see a placenta previa, let's say you're scanning a woman, you're doing a 16 or an 18-week survey scan. She's got a placenta previa. What I suggest you do is make an effort in that woman to see where does her cord insert. If her cord is inserting, as we see here, high up way away from her cervix. Even if her placenta starts to atrophy over the lower uterine segment, she is not going to end up with a vasa previa, because her cord is not in danger of being over the cervix. But if her cord is low down where it inserts and she starts to migrate, she can be in trouble. And the reason I suggest you spend some time looking for the cord insertion, let's say at 16 or 18 weeks, is it's much easier to determine where it's inserting at that point in pregnancy than waiting until she's 34 or 36 weeks, and then the baby may be obscuring the posterior placenta in a case like this, not allowing you to determine where the cord is inserting. So spend a little time when you have a placenta previa in the second trimester to try to determine where the cord is actually inserting. Here's another example. Cervix looks like, vessels for sure, but when we put the Doppler on, in this case, all we could see was venous flow. And what this represents is what we call the marginal vein around the placenta. There's a large vein that surrounds the placenta. This is a placental vessel, but it is not a cord vessel. And so a woman who has this doesn't actually have a vasa previa. Now, if she's in labor, again, this is where her placenta ends, at this point where the marginal vein is. It's not down here where the cervix is, where the placenta looks like it's ending. You include that vessel as the end of the placenta. So she, in this case, has veins that are dilated. These are maternal vessels. They're not fetal vessels. If she bleeds, it's from maternal blood. The baby doesn't have as, high a chance of exsanguinating. It's not good. You do not want to deliver this woman either from below. But sometimes these regress and the placenta ends up just fine. This is not a vasa previa. If it regresses and that marginal vein ends up far away from the os, she's going to do fine. She does not need to be delivered in that case with a C-section. So false positive vasa previas include what we call the obligate cord presentation, where it was just the cord in front of the head. That woman was not in labor. You don't worry about it. If she is in labor, she needs to have a section. The marginal vein that's around the placenta. And sometimes you just have dilated veins on the cervix, so-called cervical varices. So with respect to evaluating for placenta previa, very often you can determine where the placenta ends with an abdominal scan. I think a translabial scan or probably a transvaginal scan are equally good. You don't need to do a transvaginal scan if the translabial scan works for you. So I think either of these can be done. I don't think it's necessary to say you don't do a transvaginal scan when somebody has a previa. Used to be said that maybe you could precipitate bleeding. Don't forget that bleeding is coming from up above the internal os. Your vaginal probe is not going up there. So don't worry about that. You can do a transvaginal scan when you're trying to evaluate a placenta previa. So I always thank Dr. Netter, whose pictures I use for diagrams, and I want to give him credit here, and I want to thank you for your attention.